Good morning, everyone, and welcome to the webinar. So excited to have you today. We are going to talk about modeling a pre- and post-procedure bed space for an interventional platform, which is quite an exciting and a new concept. Just before we get started, we have a little bit of housekeeping. So just so you all know, this session is being recorded, and it will be available on the website afterwards. And that's SIMUL8healthcare.com. If you have any questions during the session, we would love to answer those questions for you. Please use the Q&A panel on the right side of your screen. There should be a chat box at the bottom, and send your questions over. We would love to answer them at the end of the session. In the meantime, you are on audio, but you are on mute, so you will not be able to speak during the session. So please do use that chat box. So let's get started. So really welcome to the session today. This is going to be a really interesting discussion today, and it's going to be presented by Frank Zilm. He is the Director of Healthcare Design at the University of Kansas, where he lectures, and he also has, relevant for this particular discussion, 30 years of experience owning his own firm, Frank Zilm and Associates. He, as part of that experience, he has worked on over 300 planning studies, so he is quite experienced in this area. And he is also an active contributor to the healthcare community as a whole. That includes authoring papers, regularly teaching at the Harvard Graduate School of Design Executive Program. He serves as the president of the American Institute of Architects Academy on Architecture for Health, and he was also a founding fellow of the American College of Healthcare Architects. So quite a resume. Really excited to have him present to you today. With that, I do want to just turn it over to Frank. This is going to be a really great presentation, and I think you really want to pay attention because it's a unique opportunity to explore how process changes and operations have been tied into their operational planning, building a facility that's really going to support their needs in a way that wasn't historically able to be done in the existing building. It's also really innovative in that they're doing some really creative design work to build in flexibility and the ability to grow the program as needed. So with that, I want to introduce you to Frank and hand it over.
Okay, thank you, Brittany, and good morning and good afternoon, depending upon where you are located. I was going to try to get the webcam here working so I could at least wave to you and you could determine that I'm really not a bot, but my computer seemed to get traumatized by the idea of showing my image across the internet, so I won't be able to do that. So you'll have to trust me, I really do exist. And as Brittany mentioned, I have had the opportunity to do a significant amount of simulation modeling going all the way back to really actually 40 years ago in batch mode with key punch cards and IBM mainframes. So those of you that are familiar with simulation as a tool understand how robust and sophisticated it can be in dealing with complex problems, which what I'm going to show you today is a way we built what I would consider some relatively simple models, but use them in a way to help us deal with a very complex problem of scaling out the support areas for a new concept for the hospital. I'm hoping that during our session today that Kelly Baumer from St. Louis University will be able to join us. She's a vice president for special projects and was a key person in our help in making this success. For those of you that are British, I want to apologize for my Midwestern accent. You'll just have to cope with it and translate process into process and schedule into schedule. And if I butcher any other phrases that you're not familiar with, just add it to the question and answer session, and we'll see maybe between Brittany and I, we can translate things for you. Okay, so here's what I'm going to try to accomplish. We're going to try to look at, just give you a brief overview of interventional platform, talk about visioning process that we went through in this case study, the development of the models, the output, and then leave things open for questions and answers. I'm assuming the audience is a mix of clinical professionals, system modelers, and hopefully architects and planners. So I'm going to go over some basic fundamentals just to make sure we're all on the same playing field in terms of understanding the general concepts and what we're going to try to do. So bear with me if I touch on something that seems fundamental to you. I'm hopeful it will be of benefit to the other participants in this conference. So context. In the fall of 2015, the SSM system in St. Louis reached an agreement with St. Louis University to acquire St. Louis University Hospital. The existing hospital is shown on the left side screen. It consisted of multiple, typical hospital of its generation, multiple phases. The initial tower was a 15-story, very iconic building called the Deloge Building, which is still being used for patient care. There were a number of additions of varying age and quality and functionality, and the commitment that SSM made to St. Louis University was that they would build and open a new hospital within a 5-year time frame. And 5 years sounds like a long time, but anybody that's been involved in the planning, design, and construction process realizes for the scale of hospital we're dealing with here, 300 beds and outpatient spaces, that's an aggressive timeline. So about a month after that agreement was made, I was selected along with 4 other firms to lead the initial planning of the project phase, working with a very strong leadership team composed of SSM and St. Louis University physicians. And the goal of that initial process was to basically get to a point that we could accurately scale all of the elements that would be involved. And it was the challenge were twofold. One was that we were given basically a 3-month timetable to program the entire complex, which was extremely aggressive and just happened to include Christmas and Thanksgiving holidays in it. So it was 3 months minus some holidays that we couldn't really have client meetings. The second challenge was a very tight capital budget. So we had to be looking at innovative ways to do things and also cost-effective ways to do things. One of the problems, if anybody that's been involved with a process like this, or process, whatever the right term is, realizes that if you look at behavioral economic studies and other studies of human behavior, when someone's approached with a problem that is perceived as a high-risk scenario, we tend to become very conservative. It's human nature. The creation of a new complex opens up the opportunity to look at new ways to do things. And the challenge that we had was to bring to the table possible new operational and organizational models for St. Louis University to look at and allow the users and team and leadership to have sufficient information and time to make good decisions. So not all new ideas are appropriate, but we wanted to make sure that new ideas were explored and presented in a way that there could be careful evaluation and consideration of them. So the blue boxes you see in these diagrams were workshops led by Kurt Solomon, who was one of the teams that was involved, and the goal there was to look at current process of the different units and to develop possible alternative strategies with the renewal project on how to approach these. So we had roughly 12 team members working in this phase, working with different components. And the component I'm going to talk about today is the interventional platform. And just to make sure we're all on the same page, if you look at a traditional hospital, you will see multiple components that are involved at some level of intervention, a direct intervention with the patients. The traditional component is the surgery suite, which consists of operating rooms, support areas, and typically what we would look at would be patient prep and recovery areas for discharge patients, which are called phase 2, your PACU recovery area, post-anesthesia recovery, and inpatient hold. So that would be one component. Typically under the same roof you would see a separate component that might have your interventional imaging components, typically being run by the imaging radiology service, and they would also have their own patient waiting prep and recovery areas. And then you would have cardiology that might have cath labs, EP, and in this case even a hybrid procedure room, again with their own waiting prep and recovery area, and then endoscopy again with procedure rooms, support space, and patient care. So that is a fairly traditional model. It has some clear advantages in that each of the components to a degree has complete control over the performance of their area. They also have to deal with complexities that can occur. For example, if cases are running late in endoscopy and you're only staffed to run your recovery area until 6 o'clock, what do? How do you manage the patients? And how do you deal with overall duplication of services in terms of just even things as locker rooms and break areas? So one model that's emerged over the past decade is called the interventional platform, and the idea here is you're trying to build in adaptability and flexibility over time by making common room sizes wherever you can, so you can adjust the function of the room to the particular modality, design it in a way that you could logically extend it, because typically when we're planning at this stage we anticipate what we call SDNT, which stands for some damn new technology. So usually by the time the project's completed, there's something that needs to be accommodated that nobody had anticipated at the beginning of the project. And then the other key element is the ability to consolidate prep recovery, and I'll talk a little bit later what we're calling phase 2 areas in a way that you can assure maximum effective utilization of the space. So for example, if cardiology physicians go off to Las Vegas for a conference and their workload drops down, that those rooms would be available, those prep and areas would be available to other services to take advantage of. So the idea is how to get maximum utilization of the resources, to position things in a way that you can deal with adaptation and change over time. So just a small scale example of that, this was a project I worked on a few years ago at University Medical Center at Princeton, and I'll try to see if I can draw here without causing too much trouble. That's not what I want to do. Hold on. Here we go. So if you look at this floor plan, this area is the operating rooms. This area is the cath, EP areas, and this area is the interventional platform. And then supporting that, we have a common prep holding area, and then a common PACU. And I'm sorry, I forgot my friends in endoscopy. They'll probably offer me some free procedures for doing that, but endoscopy was also a piece of this. And actually, this is a good case study because during construction, it was determined that they needed to add a hybrid room in, so they were able to modify this concept and adapt it to accept a hybrid room, and all the other pieces worked. So that's a small-scale example of what an interventional platform is. What we had to do in terms of our work at this phase was develop what's called a space program, and that's to identify every square foot of space and the major functions of that space that would be involved in the interventional platform at St. Louis University. We're dealing with hundreds of rooms and areas that would need to be accommodated. So conceptually, again, this is the diagram I showed you earlier. This is the Deloge Tower, a 15-story, again, iconic building on the campus. This was the building site that was being looked at, and if you look at the right, you'll see the massing concept for the replacement hospital. And then what we're going to deal with then is the essence, what's the first floor of that, which would include the procedure rooms in the interventional areas, staff areas, and then the different support areas associated with it. So the challenge was how to scale those support areas. This is a diagram of what it was looking like in early schematics. Again, this is the operating rooms, the interventional rooms, cath labs, endoscopy, and this was the support functions for that, including PACU, PrEP, etc., that I'll be focusing on in the discussion. So the challenge was how to scale this. There's different rules of thumb if you look at different areas that may or may not have validity. For example, the Facility Guidelines Institute in the United States for operating rooms had a minimum standard of 1.5 PACU beds in their 2014 guidelines, which I have found from my research and past experience to be a very poor indicator of the true need for PACU beds. Particularly if you look at the difference between a major tertiary hospital and an ambulatory surgery facility, you're going to get radically different numbers. So there were not good standards that we could identify, and due to the time pressure that we were dealing with at the 3-month target, what we agreed to do with leadership was to basically put a placeholder in for our best estimate of the square footage needed for the support areas to meet that 3-month target so that the project could proceed in terms of validating the project budget and validating the, starting to develop the overall concepts. And then shortly at the beginning of this year, with a 2-month target timeline, we initiated a process to validate what's the right mix of beds. So the process that we went through, I think, worked extremely well from my experience. What we did is we brought representatives from all of the components, cardiac cath, imaging, radiology, imaging services, endoscopy, and the surgery suite together. We explained to them what we were trying to do in terms of we were trying to estimate what's the right number of post-anesthesia recovery areas, beds, PrEP phase 2, and here we're talking about phase 2 being a lower level of observation of patients, and these would be in individual rooms. A PACU would typically be in an open bay area. What we were calling a phase 3 area, which was basically a recliner area where minimal anesthetic patients with minimal anesthetics are patients having an extended procedure that could be observed in an area would be managed through recliners. And so this was the, for the main hospital, this was a new concept. The hospital had 2 separate surgery location sites, and the remote location site had some experience with this, but for the main hospital it was a new procedure for them. And then the last piece was a short stay unit, which would be a 23-hour observation unit. And I would argue in my experience that observation beds in the United States have kind of been under-recognized as a component of healthcare delivery for a number of reasons, one of them being financial, but it's not uncommon, and certainly in this case situation, observation patients, and I'm defining observation patients as 23 hours or less, would be sent to a nursing unit floor, to occupy an inpatient bed, which at this case was occupying a bed on a unit that are typically a very high census level. And then one thing that you see at many cases like this is once the patient is moved to an inpatient unit, they start to be managed at a pace that's similar to other inpatient activity, as opposed to a short stay unit where the again, the goal would be to move that patient as quickly as possible. So one of the things we were proposing here, which for this hospital was a new concept, was immediately adjacent to the interventional platform, we would have a short stay area that would manage 23-hour or less patient care. We wanted to be able to test the sensitivity of our results to what I call what if we're wrong scenarios. How do we design in to the degree we can flexibility, because as you'll see in many cases we're dealing with working assumptions and best judgment as opposed to hard data about how the system will work in the future. And then to be able to recommend back to leadership any adjustments to that preliminary space listing that we made. So that was the task. My favorite quote is this one, and again, I think the challenge is, could we build models that would be effective in helping us make judgment decisions. So that's the challenge that we had. What we did is, again, after we met with each service, we then worked with the individual services to develop models of anticipated flow for the major patient types. We established prototype schedules for patients. We then ran the models, reviewed those models with the leadership, with the representatives from each service, tested the sensitivity. We reviewed our findings with the staff from each service before presenting it to leadership, and then presented to leadership adjustments that we felt were appropriate based on our modeling and feedback from the users. So heavy user involvement, very positive from my experience, user involvement. So what we did, and I'll show you a blow up of this, so it looks like an eye chart now, but I'll show you something that's got a little bit more detail. What we did is for each service we did a Visio flowchart of what they were doing today, and then we started to talk about if we have these kind of components and a new facility, how would you anticipate using it? What we found is across the 4 major services there were 19 different types of patient procedures that will be managed in there. So a fairly complex mix of different types of patients, each creating different patterns of demand on the pre and post procedure areas. So just to take one, and I joke about this, close to my heart, is electrophysiology. And as you can see here, what we're saying for our future model is we're saying 60% of the cases would be outpatient cases, 40% would be inpatient cases, and there's slightly different flows for each of these patterns. So for the outpatient cases, we're anticipating 60 minutes prep time, where for the inpatient we're assuming most of that prep is occurring in the nursing unit, and there'll be a shorter stay, primarily a holding stay in the interventional platform area. Procedure times, and any of you that are familiar with electrophysiology know that those procedures can go all over the place in length of stay, so we had a pretty broad distribution on the length of stay. But after the procedure for the outpatient area, 75% would be going to the short stay unit, and that was a significant change in how they were currently managing patients, but they felt that that would be appropriate if that resource was immediately available to them. The others would go to phase 2. It's kind of hard to read here. Would go to phase 2, and then they would be discharged. For the inpatient side, just to follow through on this particular example, 90% were anticipated to go back to a phase 2 area before going back to an inpatient unit. 10% were anticipated to require a post-anesthesia recovery. So basically we did these kind of models with every service in, if my memory is correct, we had at least 2 reviews of the process, and it was a very helpful step, because as they got more comfortable with what was being envisioned, they did make, many of the teams made some modifications to say, you know, we were evaluating this, and if we do have short stay, we might change how we do things. So that was step number 1. We developed the process, and then the next thing we did was to develop a prototype schedule, and it was a fairly straightforward. We used an Excel spreadsheet, and we said, for example, what you're seeing on the left is this operating rooms, and there, rather than go into specific procedures like open heart trauma, we divided the flows into short OR times, medium OR times, and long OR times. And as you can see, for example here, we're anticipating that 6 of the operating rooms would have a long case. It would be the only case done in that room, starting at 6:30 in the morning. And that's a little bit unusual, but they did have some fairly complex tertiary procedures, and that has a significant impact, as I'm sure you can realize, on the demand for PACU beds. You compare that then to the short stay, where we're using 5 rooms, and we're bringing them in a sort of an hourly pattern into the system, and making a break between morning and afternoon. And anybody that's tried to model operating rooms, I'm sure you recognize that you really don't deal with a day schedule, you deal with 2 half-day schedules. And a lot of the times, if you get a case cancellation or a break in the morning, it's difficult to move that afternoon case up in all cases, because it may be a different surgeon that's having clinic in the morning that doesn't come in into the afternoon. So modeling the actual scheduling of what happens in a surgery is a very complex problem. This is a fairly simple a way to try to resolve that. And one of the things we used was a scheduling module in SIMUL8, which allowed us to vary that actual time of arrival, trying to reflect the fact that you may plan to bring a patient in from the waiting room into the prep area at 9:15, but if things are backed up, you may delay bringing that patient in for 15-20 minutes. Conversely, if a case breaks early, you might try to move the patient in from the waiting area into the prep area a little bit ahead of schedule, or bring the patient down from the floor. And so on the other side, you can see the cardiovascular, we're moving diagnostic patients through at a pretty fast clip, a 30-minute clip. Interventional, we're starting to stretch it out a bit. Again, heavily emphasizing the morning electrophysiology, hybrid, and TEE cases. So we, again, did that for each of the 19 different flows that we had identified coming through the interventional platform. So then we did make some key assumptions in our modeling. We assumed that inpatient, there would be no backup in the surgery suite because of boarding issues and finding inpatient beds available. We are working on the assumption that our estimate of inpatient bed needs would minimize any backlog into the interventional platform. So we're saying the ability to move patients through is going to be primarily due to the resources on the interventional platform. We also assumed no siloing of beds, in effect, that all the prep and phase 2 beds would be shared, so that a service couldn't say these are our 6 prep phase 2 rooms, and if we're not using them, in essence, too bad. So they would be managed in a way that you get the maximum use out of the prep phase 2 resources. We did assume that inpatients would be handled in the prep area rather than the PACU area, which was a change of procedure for them. We looked at the mix of patients, as I mentioned earlier. One of the issues that you'll see emerge was the demand for PACU beds, and we made different sets of assumptions. One assumption we made was that only 30% of short duration surgery patients would be routed to PACU. The remaining 70% would go to phase 2 or to phase 3. And then we also assumed the turnaround times we had would be built in, and that's the cleaning of the room, prep of the room. So this is a screenshot of the basic SIMUL8 model. Each of these icons that you're seeing in the screen is a sub-window. So we have a process that I'll show you for each component, but we identify them. Each area has its own sub-window, so you aren't confronted with a mass of flow diagrams on the home sheet. And then we modeled the beds as resources. So we have basically different beds that we say are the resources that will be drawn on at different points in the process. And one of the things I learned as I was working on the modeling is that at least the version of SIMUL8 I had certain defaults built into resources. So they had travel time, for example, as a default value in the resources. So we had to go back in and adjust that to say that's not the way we're going to use resources in here. We're not going to have travel time. So you would need to be careful to make sure that the defaults on your resources are consistent with how you want to use the SIMUL8 tool. So just to blow one of those sub-windows up, this is the interventional cath area, patient arrivals. We then randomly distribute those patients based on the probabilities between inpatient, same day, and then outpatient, inpatient, and same day. I got those reversed, excuse me. Grab a prep area, do the procedure area, and then based on the flow charts we looked at either earlier route, which way the patients would go. What we did then is, as we approached an area, so if we go to the prep area, the patient we would request the appropriate resource, and again that would be in this case the prep 2 bed resource. Now, as I'll show in a second, the strategy we were using on the prep and holding areas is that we wanted to model this as an unconstrained variable. So we did not want to be in a situation where the prep and the phase 2 beds were restricting the ability to use the procedure rooms, because for a variety of reasons. One, it's bad patient care. 2, it's underutilizing the maximum resource you got. And 3, the last thing the CEO wants to have is irate surgeons storming into the office complaining about how bad the system's working. So for those reasons, we said we want to make sure we think we've always got enough beds to meet the maximum demand for those resources, which means that on average we're probably not going to have full utilization. So we also tried to insert, to the degree we could, variability in the procedure times, usually mostly average off of mean for some of the cases, and in some of the longer cases, such as the holding bed scenario, we used a uniform distribution between 6 and 23 hours and said the length of stay in the short stay unit's going to fall somewhere in that. So we introduced variability both in the scheduling of arrivals of patients, the distribution of patients, and then the length of stays at different locations in the pre and post area. So this is just showing a typical run that I'm sure those of you that have done SIMUL8 before are familiar with. We're looking at time across the bottom in minutes. We're looking at number of beds used. This happens to be phase 2 beds. And if you could see the time scale a little bit more accurately, many of you would recognize what's going on here. First of the day, we're getting a peak demand because we're basically filling up all the phase 2 beds in terms of prep for the different procedure areas. Everybody loves to start early. And then typically what you see is sort of a second wave that comes in around 11, 12 o'clock in the day when we get the returning patients from the procedure areas coming back for phase 2 recovery, and we're moving the next wave of patients in for holding prior to procedure. So we typically see a couple of spikes in the demand, and then obviously the nighttime across here. So basically we took that data from the output from the demand, and we translated it into Excel spreadsheets where we looked at the cumulative demand for different types of beds. So what you've got on the vertical here is the cumulative demand, which you're seeing in different color codes of the different types of beds. So for example, we could say that 90% of the time we use 28 beds or less. And again, what we're looking at is the 100%. We're basically saying we want to build this to the 100% level, because we don't want these beds to be a constraining variable. One could argue that you might be able to develop models that could move patients to different areas. We didn't get into that simulation in part because we said, well, that's not the desired model, even though that might be what you would do if you were actually confronted with a capacity issue. So what we see across the top here was where we left things when we finished the initial programming. These were the number of beds we had placed in there, and I will have to confess, and I see that Kelly Balmer has joined us as a panelist here, and she can provide more insight on this. I'll have to confess that in my opinion, I probably oversized these areas. I know I oversized them based on my judgment. Again, we didn't have hard data to verify that, but what I didn't want to have happen is when we came back with our refined numbers and the numbers we felt accurate, is that we blew up the budget. So my hope was that what we would come back and report will be something smaller than what we had originally put in there as a placeholder at the end of the programming stage. So what you see across the bottom then was our first initial results, where we said we needed 40 phase 2 areas, 11 PACU, 14 phase 3, and 16 short stay. A couple of surprises out this. One was the PACU number made the PACU nurse extremely nervous. I think might be an understatement, and it was a surprise to all of us, so we went back and looked at that. This number of short stay beds was interesting because I really do think it was reflecting some forward thinking by everybody involved about how care will be provided in the future. So this was a bigger number than we'd anticipated, but I think it really reflects a shift in care that is an appropriate assumption about how they'll work in the future. So we then did some sense. Yeah, Kelly?
So this is Brittany. I just have a quick question for you. You said earlier that there are standards about ratios, right? 1.5 beds per OR, whatever the number is.
Mm-hmm.
How do these numbers compare to that? Do you know that off the top of your head?
Oh, no comparison at all. For example, there's 14 operating rooms, so if you use the FGI guidelines, you'd be talking about 21 beds. Mm-hmm. And so, again, part of the problem with, in my judgment, and FGI guidelines, facility guidelines are very good overall, but I think this is one area where, in my judgment, they dropped the ball because setting a standard like that, again, doesn't reflect the diversity of types of operating rooms you'd be talking about. Here we're talking a very low percentage of low acuity patients, a very high percentage of long procedure time patients, which then allows you to clear out the PACU. So I would say in most cases our numbers were coming out under the kind of rules of thumb that you might encounter as you look through the literature. Okay, so
Awesome. Thank you.
Brittany, did that answer your question?
Yes, that's great. Thanks.
Okay, so we then did some sensitivity analysis of our initial assumptions. We said, okay, what if 70% of the short stay patients went to PACU rather than 30%? What change does that make? So that bumped that number up a little bit, bumped this number down a little bit because we weren't taking them to the phase 2 area. We said, what if 70% of the surgery short stay and all long cases went to the PACU, and then that bumped that number up. This number stayed the same, which was a little surprising, and again you can see the short stay numbers were holding constant because we really didn't vary that in the initial sensitivity analysis. So we reviewed all of this with, again, representatives of each of the services and took them through how we model this, and again, we just looked at different sensitivity. And basically, we got sign-off on the following adjustments to the original program. We were going to shift 6 beds from the phase 2 area over to short stay to meet that 16-bed target, and then we were going to shell beds to allow us to deal with potentially future growth, or what if we're wrong, what if one of our assumptions went wrong. So we're basically saying we'll end up with 44 prep phase 2 beds, 16 short stay beds, but of the 44 you'd have some shell. We would shell PACU beds, so originally we had 16 beds in our program. We said we'll go with 12 initially in shell, and then we reduced the phase 3 area, which is the recliner area, to 14 stations. That was presented to leadership at within that 2-month timetable, and basically accepted with I would say minimal questions. I think people understood. The key thing is people understood how we attacked the problem, how we approached it, how we analyzed it, what the models were saying, and then what adjustments we were making. So Kelly, who was an absolute key person in this process, Kelly Balmer, was the Vice President of Special Projects, and she has been working at St. Louis University since 1997 and had extensive background knowledge of how things worked and a great deal of trust by the team members. And Kelly, I don't know if you want to make any comments about your observation of this process or anything that might have transpired since we completed the modeling work.
Yes, no, the thing I think I just want to add to all the things that Frank has said today is that this modeling process was really crucial to getting us to an understanding, because as you looked at the models that Frank was presenting, you can see that we have a great deal of variability in procedure times, in the kind of complexity of work that we do within our cath labs and in all the various interventional areas. And so that it gave people, before we did this modeling, it made people really nervous to kind of say, are we building these PACUs and pre and post-op areas correctly? And it took a lot of work by the team, and it really does take engagement, not only by your leaders, but really by your frontline staff who are doing the work every day. And so Frank provided great spreadsheets for us. We actually took a lot of time to go through and model it, and then once we showed the work groups the product of the models and how we came to it, I think it just really, it made our physicians feel more comfortable, it made our staff feel more comfortable, it made me feel more comfortable as in charge of the project, and really it was able to then, you know, get the team that needed to sign off on the space comfortable that we did what we needed to do to vet everything. So I just want to say that I think it was a great process for us to go through, and it really made a huge difference in our comfort level about how we were sizing the space, where we were putting the beds, etc. So,
Kelly, this is Frank. If you're comfortable, if you would feel comfortable talking about it. My impression is from the physician perspective, there was some continued concern about the interventional platform concept. So my understanding is that you've done a number of site visits to try to better familiarize the team with how interventional platforms have been operating at academic medical centers.
That's correct. We visited 3 different academic centers that have done recent constructions, and actually have another visit to go after the first of the year who've done this same concept. And I think, as Frank told you at the beginning, our situation currently is that we have an outpatient OR, four outpatient ORs about a quarter of a mile from our campus, where a lot of our outpatient work is done currently. And so really the biggest concern that we had was bringing those ORs, the inpatient and outpatient ORs, into one platform. I think that was probably the most concern that our surgeons had. A little bit also then in bringing the whole interventional platform, all of those areas, endoscopy, IR, and cath together. But I think really the biggest concern was from the physician side, because the surgeon side, because we are in an environment where we do level 1 trauma, we do transplants, and so the concern is if you bring these outpatients in with your inpatients, they're going to constantly get bumped for these emergent procedures that have to go into an OR suite right away. And so we spent a lot of time working with facilities that have done this successfully on the process and how they've kind of allocated those rooms. And so we learned some things about fast-track processing and things like that I think, again, our physicians are now more comfortable moving forward with this integrated platform. So that's something I would encourage. And we looked at facilities that were just like us, that had the transplant, that had the trauma, and the surgeons there were saying this model works. So I think it's helped to get us then to continue moving on with our design.
Thanks, Kelly. I appreciate that that input. I think we're open for questions. So
yeah, so let me jump in. This is Brittany, and thank you both, Frank and Kelly, for your insights. Kelly, can I ask a follow-up question? You said you really thought this process worked well. Is this a process around planning that you had done before, or was this kind of a new approach that Frank was bringing to you, and do you have any reflections on that?
So no, this is a new process for us. So again, as we went through our planning phases with Frank, we talked about sizes and beds and what our procedures look like. And what we quickly realized was that, okay, well, what about the EP patient who takes 300 minutes versus the ones that take 100 minutes? What about the neurointerventional patient that comes in emergently? What about the whatever procedure we were doing? There were so many variabilities in the kinds of complexity, and we're a tertiary quaternary center, so we do a lot of complex, long procedures, as Frank alluded to, and then sometimes we may have a neurosurgery case that's in our OR for 12 hours and takes up one room, but then we have other rooms that turn over every 2 to 3 hours. So that great degree of variability left us with a lot of discomfort in were we sizing this PACU right? How are we doing our pre- and post-op beds? Now we're bringing an outpatient platform into an inpatient platform. So how do our ophthalmology patients recover? All of these things, there were so many variables, and we were like, gosh, I don't know if we're sizing this correctly. And so that's when Frank really recommended that we kind of do a deeper dive into each of these specific things. And once we saw the models, we saw them working through, it really made all the difference in us feeling comfortable with the decisions we were making moving forward. And we were on a very tight timeline with this project. We have so I think that also timing-wise it was helpful because then we could continue moving into the schematic design phase because we didn't have a lot of time for to wait 2 more months to understand this. So I think putting these models together, letting everyone see how they flowed, we got to a point where we're like, yes, we are comfortable with how we're moving forward.
Awesome. That's great to hear. Awesome. So we do have a couple of other questions that have come in from the audience, so I do want to see if we can touch on those. We can. One of the questions was around you, Frank. Do you think that every project like this needs to be simulated individually, or are there some key learnings, some ways that we could look at those guidelines and kind of reevaluate them if you're doing an interventional platform at an academic center versus an outpatient center? Could we establish some standards and improve those as opposed to doing it individually for each project? How do you think that works?
That's a good question, and I would say if there was a large enough case study database, we could be doing some things. For example, if you look at the emergency room planning, there's an alliance of emergency rooms that annually reports statistics and data that you could start to get some basic descriptive statistics that might alleviate some of the questions that we were wrestling with in the interventional platform. My experience and knowledge is there aren't enough of these in play, and they are relatively different in scope that I don't know to what degree you could develop and affect a generic model or a generic set of recommendations that would be appropriate for all the different settings that we're dealing with, particularly if when you insert the element of an academic medical center. One academic medical center is just like one academic medical center. You know, they're all zebras and different. And so I would be, at least at this stage, pessimistic. Now, maybe down the road and in the future, if we've got hundreds of these, that we could start to aggregate operational and demand statistics. You could look at trying to establish some basic guidelines, but in my judgment, I don't think we're there yet.
Fair enough. Sounds like your future research project at Kansas University. Cool. So another question here coming in from the audience, looking at how the long procedure time allowed you to clear the PACU and reduce the number of beds. And the question is, how did you do some sensitivity analysis around how many people are going to be in those short procedures versus long procedures? What if those new technologies come in and maybe shorten procedure times? How does that affect the need, and what kind of flexibility do you have along that?
Well, again, those are great questions, and or a great question. Let me rephrase that. We worked with the surgery suite leadership to develop the prototype schedules. Now, I will say that while we varied arrival times and we had variation in length of stay, and we had variation in terms of the routing, particularly the short stay, we didn't do a lot of sensitivity analysis on the assumption that 6 of the rooms would be long case rooms, and that might have been something that we could go back and perhaps, if time would have allowed, could have gone back and tested. But just thinking again off the top of my head, which is always dangerous for me, if we're talking about the difference between an 8-hour procedure and a 6-hour procedure, I would argue that typically that's not going to have a significant demand on the PACU area, because usually, again, if you look at most PACUs, they're peaking out in late morning and early afternoon, and then as the workload starts to taper off, their demand drops down. So if we had a case that went 6 hours rather than 8, or if the average changed, I don't know if that would have a dramatic impact. But if you remember, in our recommendations, we did put in some shelf space just to say, you know, what if we're wrong? You know, what if things go in a different direction? So again, I think everybody on the leadership team recognized that, although they were on an extremely tight budget, recognized that that was a reasonable strategy to try to keep the interventional concept, but by some flexibility if the original modeling assumptions didn't turn out to be right.
That's a good point. Great, thank you for that. Last question here from the audience. The question is, rather than looking at the number of required units, I think maybe they need beds in that case. Have you considered using simulation to design the layout and a physical layout of the unit using the simulation as opposed to just looking at sort of total capacity? Have you done that before? What is that like?
Well, yeah, our particular role in this case was to develop the space program, so we didn't have a floor plan to work from. That would be kind of a logical next step. particularly, for example, in emergency room designs where you've got hundreds of patients flowing through a particular layout, looking at that flow and evaluating how that's working in terms of basic traffic and implications on access to different areas, I would argue is an important consideration. That would have been a logical next step as the project moved into schematic design. The architects involved did not choose to do that. They did some other techniques to look at flow and layout, but that would be a logical sort of next step in this kind of a modeling exercise.
Awesome, great. So I have a question then for you as well, and Kelly, this is also for you. Did you come forward to this project with a, yes, we're doing an interventional platform and it's going to be dynamic and we're going to build in some of this flexibility, and did you come forward already having that agreement in place given your short timeline, or was that on the table? Does it make sense to put all the pre-post sets together, does it not? Was that a question you were evaluating, or was it pretty well established when you kicked off the project?
Yeah, Kelly, let me take a first shot at that, and then you can correct me if I see something profoundly wrong. We, at the beginning, established task forces for the different areas, and we did establish a task force for interventional services, but we did not come in saying we're going to do this. We proposed this as one option and worked with them, and again, I would argue that one of our roles as being kind of the outsiders is to bring in ideas from other areas, from other experiences, and to say, do we think this would work in your case? And that task force group, which again had representatives from all of the different services involved, basically concurred that the interventional platform idea was appropriate. Now, I'm not sure, and Kelly may be able to outline this, but my suspicion is that not all of the physicians are 100% convinced that this is the right way to go. But that's not unusual in this kind of a planning process. If you can get 100% buy-in to a concept, it's a very rare case, and you ought to go out and party for a couple of days if you can do that. So I think there's still some concern. I wouldn't be surprised if a lot of it has to do just about the ability to control your own processes and make sure they work right. So Kelly, I don't know what your observation is.
Well, I would say that I honestly have not had a lot of, I don't think there's a lot of concern on the non-OR side as far as like cath lab, IR, endoscopy, because right now we have, there are various floors in our hospital, and we really have, we have prep and recovering areas from these procedures that are very undersized. We're constantly having patients in hallways, and so I think that they feel that a combined platform really makes a lot of sense. I think that the biggest still concern that I see from their doctors is the combination of the inpatient and outpatient ORs in one platform. That really is, I think, the one kind of still remaining concern, but I think that we've done a lot of work and also visiting facilities and seeing how they've done it successfully, that we're really starting to kind of get through that. But again, our outpatient surgeons are most concerned with being bumped because of inpatient emergent procedures, which is kind of part of our core business here. So I would say that's probably the one remaining thing that we're still getting our surgeons to a comfort level with. But I feel like the interventional, the rest of the interventional physicians are really pretty happy with kind of how the process is moving forward.
That's great to hear. So is this something that you learned from your site visits, and are you able to share, if it's okay, are you able to share where those visits were?
Yes. So we visited Stanford, and that was a little bit more about the outpatient side. We visited the University of Utah, which was both on the ambulatory side and the inpatient hospital. Stanford is in the process of building a new facility, a new hospital, but they've just built a new outpatient facility for ambulatory care. The University of Utah is in the process of adding to their hospital, so we learned a lot from them. They're still in that process. And then the platform that we looked at that has been implemented that was very helpful was the Zuckerberg San Francisco General Hospital, which is the University of California, San Francisco academics are the ones that are the physicians at that facility. And they actually developed a very successful fast-track process, especially for like outpatient orthopedics, where they basically have a concept where there are 2 OR rooms. They can never be bumped, and they're only for outpatient procedures that are 90 minutes or less. And they've been able to double the amount of procedures, surgeries that they do for outpatients in a day. And they have a dedicated team of people. And basically how it works, and again, it's process-driven as well as design-driven, where they have an extra circulating team. And so as one team is in the room doing the procedure, the other team is prepping and doing everything they need to do to get the next patient ready. As soon as that patient 1 is finished, that team brings that patient out to recovery, and then the second team is ready to go into the next room. And so they have turned their turnover time to almost negative numbers, and it's been very successful for them. And so we learned a lot about that, and that's something that we're actually working on in our current facility that we're hoping to take to the new facility.
That's fantastic. Really interesting. Well, I do want to wrap things up here. So thank you, Frank, for the presentation. Do either of you have anything else you want to mention before we close out?
Well, again, I would just like to thank SSM for allowing us to share this material with you today. And again, as I mentioned at the beginning, I think one of the keys to the success was having a strong leader from the project to work with the group, and appreciate Kelly's serving in that role. So.
Well, thank you. And Frank, the one thing I just want to add is, Frank and his team, they were really good listeners. So I'd say the people that you work with, really engaging your frontline staff in the process is really the key, because they're the ones that know all the current challenges they face, and they always bring a lot of things to light that sometimes we at the leadership level aren't thinking about. And so I think engaging frontline staff, and then really having architects that really sit and listen to what the staff's saying so that we can have successful models built. I'd say those are 2 key things that we were very lucky with in this project.
That's great. Thank you both so much. I really appreciate you taking the time, and it's really been fantastic to hear about this project, because I think what's really important is that we remember that simulation is part of an integrated project, right? It's not the focus of the project. The modeling isn't the point. It's not the final conclusion. It's the technology that facilitates the discussion, that facilitates the decision-making, helps you make those plans better, and I really appreciate you putting it in that context for us today.
Okay.
Thank you, everybody, so much for your time, and we will talk to you soon.
Thank you.
Okay.
Bye.